كيف الحال? So, how is the introductory course by far? Are you enjoying the course? اللي هي نقلة نوعية من البيسك للكلينيكال. How will you find this? You will enjoy إن شاء الله the clinical years. يعني تعب 3 سنوات, 3 basic years, first 3 years you will enjoy. First of the thing, let me introduce myself. I'm Dr. Mohammed Akour. I'm a respiratory physician. Inshallah, today we'll talk a continuation from my colleague Dr. Sam that gave you yesterday the first part of the history. How would you take the history? Okay. So today we'll talk about one of the symptoms, the important symptoms in the respiratory system, and it's the chest pain. So chest pain, as you can see, can arise from different organs, and can give you the same presentation. Okay, first the myocardium, the heart, and chest wall, parietal pleura, mediastinal structure, tracheobronchial tree, pericardium, esophagus, and subdiaphragmatic organs like gallbladders and these stuff. And all these are related because of the innervation. Can you remember why they share the same? For example, if you have a cardiac pain, acute coronary syndrome, an MI, we'll put a hand in the retrosternally, in the middle of the chest centrally, okay? Do you know? Anyone remembers why is that? Why the chest from the myocardium or the esophagus would be retrocentral? It's all related to the innervation. It's all related to embryology, back to the embryology, to the basics. The innervation that comes to that innervates the heart, the phrenic nerve, and the esophagus, they share the same innervation. So when there is a pain, or when there is anything there happens, the pain will be explained as an area rather than a site, okay? If it's somatic, if the innervation is somatic nerves, then you can localize the pain. So that's the difference. We'll talk about that. Pain does not originate from the lung parenchyma. Why? Autonomic, we don't have pain receptors, pernicious receptors. And from the visceral pleura as well. So it's all from the parietal. So the pain, any pain comes from parietal, not the visceral. So when there is an infection or a pneumonia or a B pulmonary embolism that causes infarction, the irritation of the visceral pleura won't do any pain. However, we start having pain when the parietal pleura is involved. Yeah? Okay. As you know, the autonomic they have autonomic, and the others they have somatic. For those, the upper six rib, they are innervated. They are innervated by somatic nerves. So you can, if there is any pain there, pneumonia at that site can be localized. Pleuritic chest pain, the secondary to pneumonia, to trauma, to rib fracture, muscle tears, anything like that irritate the intercostal nerves, that they are somatic nerves, you can localize it, the upper 6 ribs. The lower 6 ribs and the diaphragm, the central part of the diaphragm, and the subdiaphragmatic areas, they are supplied by phrenic nerve. Okay? They are supplied by the phrenic nerve. So any pain can be down there, can be felt at the tip, would be referred. You heard about the referred pain. Would be referred to the tip, shoulder tip, or the neck sometimes, okay? Because they are supplied by the phrenic nerve. صحيح, by the way, يا اخوان جميع كل تلفونات silent اذا سمحتوا, put it in silent mode. ما بدنا اي تلفون مشان نكون متفقين. Okay. So, any questions about where the chest pain can arise from? Can arise from the heart, esophagus, chest wall, say trauma, all of these can cause chest pain. So chest pain is an important symptom. And when you ask about the chest pain, you should go through any pain, to be honest. Any pain, you should go through the thing that's called secretis, the mnemonic secretis. So site, next please. Next slide please. Site, where is it? Site of the pain. Onset. Site, retrosternal pain. Is it retrosternal? When it's retrosternal, a patient put hand on his chest in the middle of the chest retrosternal, which means we get afraid. Okay? نخاف أكثر شيء most serious, it's because of cardiac origin. Okay? It might not be cardiac origin, it might be esophageal, heart pain, reflux, severe reflux, rupture, esophagitis, that will cause that as well. Sometimes, if it's not the heart or if it's not the esophagus and not MI, might be dissection, aortic dissection. The patient is dissecting, and in this case, the pain will be referred most of the time. It will be referred to the back. Okay, so to the back, which means the patient is having an aortic dissecting. He is dissecting while he's talking to you. Okay, so this is the most important. Acute coronary syndrome, as you know, they are angina, unstable angina, MI or anstomy. Okay, it's the elevation MI or non-ST elevation MI. We have another pain, like the pleuritic chest pain. The characteristic of the pleuritic chest pain that was an inspiration, deep inspiration, coughing, or even gluffing. Why is that? Because increase in the size of the lungs, so the pleura, the both pleural layers, they will up, and the pain will result. So there will be a mid inspiratory arrest called سنة arrest catch. لقط نفسي بالعربي. مش قادر أكمل لقط نفسي. It's the mid. يعني بده ياخذ نفس مش قادر يكمل. This is pleuritic. لأنه صار في there is a rub between the both pleural layers. Okay, so they won't continue that. Okay, so it was with inspiration cough. It's sharp, stabbing in nature. هاي مميزاتهم stabbing in nature. And it's away from the midline. So, فدائما it can be localized. The pleuritic chest pain can be localized. Secondary to pneumonias, adjacent pneumonias, PE as well causes pulmonary infarction, viral infections, costochondritis, and all of this stuff. So there's like Borrelian disorder, which is secondary to Kawasaki B virus, causes myositis. Inflammation of the intercostal muscles, okay, causes myositis and causes pleuritic chest pain as well. The enterovirus, as you can see, enterovirus, Coxsackie virus is part of the enterovirus, so the big family of enterovirus. And Teat syndrome is the costochondritis. Sometimes after an upper prodromal viral infection, upper respiratory infection viral, sometimes you may have retrosternal pain or sternal pain. Sometimes you can if you get it once, you won't forget it, to be honest. If you get it once, you won't forget it. It will inflammation of the junction, costochondritis, of the junction of the rib, between the rib and the cartilages. Okay? And it's often nasty. You can't take a complete breath. It will catch in the middle. There will be a mid-inspiratory catch or arrest. Next, please. Associated site onset. Again, onset and associated the symptoms, fever, rigors, night sweats, that might give you a clue about what's going on, what's the cause of that pain. For example, if you have fever, night sweats, or rigors, we think about infection more, okay, either acute or chronic. Fever or rigors, more of acuteness, but night sweats, more of chronic thing, like TB, for example, or sometimes malignancy, like lymphomas. Something causing invasion of the chest wall, the nerves that will cause lymphomas, like lymphomas, cancers in general, mesotheliomas as well. Vasculitis is an important thing as well. Vasculitis important, like Wagner's as well, causes sometimes chest pain. Rigors, generalized, شو هي rigors? شو الفرق بين shivering and the rigors? Anyone have an idea? When you shiver and you rigors? Sorry for that, let me rephrase it. Chills and rigors. You are right. You are قريب انت كويس. And basically كلمتين rigors is a shaking chills. Chills هو شعور بالبرد. بردية شعار عند البردية in Arabic. Rigors is the act. And why this happens? ليش? When we have a fever and the temperature is elevated, thermostat center, the hypothalamus, due to the cytokines, due to the inflammatory cytokines, it will elevate the body temperature. راح ترفع البار تاع ايش؟ thermostat. So instead of what's the normal temperature? دائما نحكي range, always in range. ها؟ لا دي حكت زميلتكم 36 3 ل 37 2. Some of them they consider 37 ونص as a low grade fever. To be honest, for me, when you consider fever, يعني لما تقرأ راح تلاقوا أكثر من literature 38 and above. Between 37 and 0.3 to 38, this is low grade fever. فاتر. اسمه مصطلح فاتر. Okay. So يعني لا ترتقي انك تسميه في dry, the patient is febrile. For me at least. Okay. Good. So what happens? The hypothalamus reset بيعمل. In order to increase the temperature, you need heat, and the heat will be generated by contractions, and the rivals will happen. Okay. So rivals is basically shaking chills. Good. So few minutes. غالبا this is due to the infection, bacterial sepsis, and there will be a cytokine release, inflammatory mediator release that will reset the thermostat and elevate it. Night sweats often comes with more chronic process like tuberculosis or malignant lymphoma or malignancy, because usually these patients they have drenching night sweats. Drenching night sweats sometimes خاصة في lymphomas. When you ask the patient in the history, do you have night sweats? عمرك سقيت مبلل بلوزتك أو t-shirt and you have to change it? This is the most important thing to have. إذا حكى لك زي this is positive. And sometimes it depends. You have to ask him يعني فرضاً واحد في الصيف الجو حامي ورطوبة. Would you consider that? But if he is drenching night sweat يعني الكل بتضايق من الجو. So you have to ask about the environment first. And if the environment is suitable, then mostly this is positive, night sweats, okay? So, again, dig deep in the history. شو واحد طول عمره زي هيك عايش بمنطقة نتيجة جماعته دائما عندهم رطوبة وجرحان ودائما بيعرق وتقول له نايت سويت يقول لك دكتور لا هذا بتفرق معهم، اوكي؟ يعني تيجي لواحد فاضي ساكن بعجلة يصير يغير بلوز كل يوم بالليل. Good. So this is the most important thing. Next, Sadaqi. Another associated symptom, weight loss, often comes with malignancy and comes with another chronic infections. Malignancy in general, lymphomas, we know what happens. Why weight loss happens? Yes, tumor, excellent. Tumor necrosis, so inflammatory cytokines, mainly tumor necrosis, causing weight loss, excellent. That's true. This is lymphoma. TB is the same, almost. Though there are this malignancy and chronic infection, they share the same common inflammatory pathways. So malignancy as well, they activate that. So most common is tumor necrosis factors, but we have different as well inflammatory markers that will suppress the malignancy and will lead to weight loss, suppress the appetite, and will lead to weight loss, and as well increases the catabolic stage. So not just about appetite, it's more about increase the catabolism, okay? And because you have cells, rapidly growing cells, tumor is basically when the cell starts obeying the body, okay? So they will start growth, proliferation without an order. These cells, they need energy, okay? They need an energy, and the energy expenditure will be taken from the patient's own body, okay, in the cells. So if the glycogen stores finishes, the fat finishes, then muscle gluconeogenesis will be taken over. Okay, that's how they weight loss. So catabolism, in addition to suppression of appetite in the center of the appetite as well. COPD, interstitial lung disease, why is that?
More effort to breathe.
Excellent, walk of breathe, excellent. So those patients, they struggle to breathe, unlike us. In the نتنفس, while we are talking, we are breathing, okay, without being aware. If you are aware, if you are breathing, shortness of breath, breathlessness, it's an awareness of your breath. So those patients, they struggle to breathe. So they probably put 3, 4, if or more effort than we do. So they need more, the energy expenditure again is increased, and hence they lost weight. Next, please. Sleepiness. Good. One of these symptoms as well, the respiratory symptom. Excessive daytime sleepiness. So excessive daytime sleepiness can be a sign of obstructive sleep apnea. From its name, obstructive. Where is the obstruction? Where is the obstruction? Upper airway. هل صوتك دكتورة؟ لا. Blood vessel? لا. Upper airway. مين حكى upper airway? So it's obstructive sleep apnea. It's a dynamic airway, upper airway collapse. That's true. And while we are sleeping normally, normal physiology, our airways, the upper airway, with oropharynx, with nasopharynx, with hypopharynx as well, they should be packed, the muscles. The muscles, they should be contracted always in order to keep the airway patent. For a reason or another, those muscles, they decide to relax. Either when they relax, they completely close or partially close. By the time the complete closure, this is an obstruction. In a muscle and a complete closure, there will be partial closure and hypopneas. So the resultant from complete exposure is complete obstruction is apnea. And apnea is cessation of breath, basically. And for the definition, for the American Association of Sleep and Medicine, ASM, the apnea should be complete cessation of airflow or more than 90% of baseline. And this is later on, inshallah, we'll get exposed to for polysomnography, for the sleep study. How would you know? And why is the definition? So more than 90% cessation of airflow. When we do the sleep study, we put multiple transducers. One of them is airflow or thermostats called. Two types. One of them, it works in temperature, different of temperature دائما الهواء اللي بيطلع مننا أسخن they can know that there is a flow and expiration and inspiration, or بيحطوا airflow transducer. Just it's the pressure difference between the pressure and the flow of the air can be detected, and if there is cessation of the flow on the inspiration for more than 90% of the baseline for at least 10 seconds, this is apnea. Okay? Hypopnea, from its name, hypopnea more than 30% from baseline. So, مطاطة. يعني more than 30% compared to the baseline. إذا البيزلاين normal, that's fine, بس إذا البيزلاين مش normal, كمان أنا ممكن يكون البيزلاين مش normal as such comorbidity. Yes, okay, so hypopnea more than 30 and apnea more than 90%, both of them for 10 seconds, and there is different criteria for hypopnea, and they should be associated with arousal as well in the EEG. But for the time being, you don't need to know more than that. Okay. So nighttime symptoms. So obstructive sleep apnea, what will happen? Just briefly, لأن الواحد نحكي لكم شوي عن sleep medicine. Sleep, stages of sleep. Why this is important? In order to understand what we are talking about and why the excessive daytime sleepiness happen, we need to know the sleep stages. Sleep stages. NREM or REM. NREM شماله. How many stages? Are you sure? Four stages. Non-REM is 4 stages. Stage 1, 2, 3, 4, and REM stage. Stage 1 and 2, light sleep. Stage 3 and 4, deep sleep. Stage 5, لحاله هو الREM. Okay? And as probably, if you remember or not, in the first stages then we always have low frequency. Okay? Sorry, we have high frequency, low amplitude that start from the frontal. When we start falling asleep, the waves will be transferred from the frontal to the occipital. So there will be discharges from the posterior occipital lobe called vertex discharges or vertex waves, basically. تمام؟ هذول بيكونوا high frequency بيكونوا في بداية اليوم they are high frequency, and as we go deep and deep the frequency will be slow wave stage 3 and 4, but the amplitude تكون high. Okay. الREM, rapid eye movement, in the EEG في sleep study we see the same waves that we see while you are awake. But لكن سبحان الله we have atonia. Imagine إنه كل EEG as we are awake يعني while we are awake there is a contractions ولا لا؟ Imagine this contraction will be translated while we are sleeping. So what will happen? Kicking, moving while we are sleeping في REM stage. لأن REM stage from its name, rapid eye movement, it's the most important stage to be honest, because there is a healing there, there is a consolidation of the memory, getting rid of the uneventful events. تتخلص من أضغاث اليوم من الذكريات اللي بدك إياها. You consolidate إذا كنت تقرأ أو شيء, you consolidate your reading. That for that it's important نحكي للناس اللي تدرس you have to have at least 6 hours and at least before 12 AM لازم الواحد يروح على البيت قبل الساعة 12. أنا I usually recommend and always recommend my patients to sleep and to go to the bed at 10. ساعتين قبل الساعة 12 is better than 4 hours after 12 o'clock. Okay. So what will happen? Why we are talking about that? While we are sleeping, the air will come through the upper airways, down the airways, to alveoli, gas exchange, blah blah, what you know. When there is a partial closure or complete closure and obstruction, what will happen? The airflow will not go down, then the oxygen exchange, oxygen CO2 exchange will drop, hence the oxygen will drop in the blood, will be reflected in the blood, hypoxemia, which will be sensed by the chemoreceptors. The chemoreceptors, we have chemoreceptors in the lung, we have chemoreceptors in the carotid arteries, we have different chemoreceptors everywhere. What will happen? These chemoreceptors will send a message to the brain, to the center, to the respiratory center. And the respiratory center will send a message to the muscles to contract, to open, in order to open the airway. Each time so when the respiratory center sends a message to the muscles to contract, this means arousal. So after any obstructive event, there will be an arousal. Okay, an arousal in the subconscious, which means إنه إحنا مش واخدة عيونك, but arousal على EEG, and this wave is the same wave as we are aroused. كأننا صاحيين. تمام? So there will be an arousal. This arousal will lead to cut of the sleep cycle. Sleep cycle basically is like the Russian roulette. اللي بيعرف شو Russian roulette. Russian roulette إذا انقطعت لازم تتبلش من أول وجديد. Good. For each time we have cut in our sleep, we have to go back to N1, N2, N3, N4, and then we sleep. We do not continue from the last part. يعني ما نكمل من N3 إذا انقطع في N3. Good. So, which means basically broken sleep. Broken sleep will lead to excessive daytime sleepiness. Patient لو نام 10-12 ساعة, he won't be refreshed in the morning. He will be lazy, fatigued, tired, and easily fall into sleep and take naps and dozes during the daytime. إذا قاعد بس لحاله, إذا قاعد على تلفزيون or something like that. Okay? So this is excessive daytime sleepiness. That's why important. So now we understand how things occur. So this is the correlation about the basic, that we have the basic, its physiology, and how we correlate it with the clinical. Good. Nighttime symptoms, sometimes snoring as well. When the message is sent from the respiratory center to relieve the obstruction, there will be a turbulence in the muscle contraction. So the muscles of the pharynx, they won't contract evenly in the same way. Good. Hence, the air that comes will be turbulent and will lead to snoring. So snoring basically is a sound is generated here. Episodes of breathing cessation, apneas, and witnessed apneas in partners or suppose or whatever. بحكي لك لما يجي مع عند دكتور sleep physiologist or sleep specialist, بحكي له إنه أنا تسأل specifically about هل بوقف نفسه for a second بعدين يصير زي هيك. So this is witnessed apneas. So this is breathing cessations. Okay. The most and snort. Snort is a sudden loud resumption of breathing when they continue. زي ما حكينا زي هيك. So breathing cessation, sudden opening of the throat, sudden relief of the obstruction will lead to snorts. The most common or the most risk factor is the obesity, and from the obesity is the neck circumference. More than 17 inches for male, and I think 16 inches for female as well. This is the high risk factor. They put the patient at most high risk factor for developing sleep apnea, simply because the area here will be crowded with the structures and muscle and fat. Next, please. Okay. So can we go back to the pleuritic vein, please? A slight chest vein, بس مشان sorry. So next slide here. So great. Site, just to elaborate more on the chest vein. Site, حكينا, we have retrosternal or right or left, wherever, localized or not localized with the hand. With the hand بتخوف أكثر. If the patient comes to you بحكي لك هون على جهة القلب حط إصبعه، إذا حط إصبعه هون ما بتخافش. Musculoskeletal, pleuritic. Musculoskeletal often there is tenderness, muscle tears. لاعبين الأثقال. Pleuritic على النفس على الكف على الشارع. It will be sharp stabbing in nature. Okay. Onset. الonset sudden or insidious. Sudden often acute. يعني more risky. نخاف من إيش في الصدن. طبعا it depends على السباكتوس. ممكن embolus, yes. One of the differential is pulmonary embolism. Female, OCD is taking oral contraceptive. She's young. While she was in war, she developed sudden chest pain and shortness of breath. You should think about embolism. Patients, often young, tall male. So we have hours, minutes to hours, hours to days, days to weeks, and more than weeks. So minutes to hours. Male, for example, female حكينا عنها. الميل شو كمان؟ male, young, tall, تمام. Healthy. He was swimming. حكينا عن VTE, venous thromboembolism BE. بس for example, a male, he is tall. يعني 1.9 meter يعني and he was swimming. Suddenly, while he was underwater diving, he developed chest pain. Yes, pneumothorax, excellent. Pneumothorax, good. Might be turbulent, yes, you're right, that's true. So pneumothorax, I'm giving example in minutes to hours, something acute. Okay. شو كمان؟ MI. Yes, aortic dissection, excellent. Sphincter rupture, all of a sudden. Embolism?
Aspiration?
Aspiration wouldn't come acutely, it would come hours to days. Okay? Hours to days. So pneumonia, whether aspiration or not, community acquired or aspiration pneumonia, are right. It will come hours to days. Patients, they often develop dry cough, and once the pneumonia is untreated and it will reach the visceral and the parietal bronchi, then they start having pleuritic chest pain. That's true. So hours to days, حكى زميلكم pneumonia, aspiration or non-aspiration, community acquired, often associated with fever, and most of the time they come with other symptoms that might give you a clue what's going on. That not might give you, will give you a clue what's going on. So what also as well, فالبلوريتك حكينا عندك الBE, costochondritis, infection as well, pneumonias, all of these cause pleuritic chest pain. The onset is quite important. Hours to days or days to weeks. For example, cancers, lymphomas, something that assiduous, built up with time, TB, good. Shokati, COPD, how would it cause pain for you? You're right, there is a pain, بس كيف تعملها؟ How, first, the onset of that and how it will be caused. And the onset. Yes. Yes, so good. Exacerbation. Exacerbation أو student. So we do exacerbation. في شيء دكتورات في شيء حكينا معك أنا عندي ما عنديش مشكلة نقول بس أنا سولف ندرس حلو الضحك على الصورة مرة تمام يلا أنتم تكونوا أفضل ما يكون الصبح بدنا نبلش نضحك الصبح خلي الضحك لبعد الظهر طيب concept character حكينا stabbing more inspiration this is pleuritic tearing cause of musculoskeletal heaviness in nature acute coronary بنخاف المريض بوصف لك كأنه في زي building على صدره شو كمان dull aching pain sometimes it happens شو بكون هذا؟ ها؟ أنا ideas pleural effusion sometimes pleural effusion building up لما once he's full بصير عندهم زي dull aching pain sometimes pain there is pain يعني مش مفسر okay invasion of the intercostal nerves by mesothelioma or the cancer direct invasion of lung cancer or thymomas or something like that so that's security is quite important the character of the pain cardiac stabbing or central pain site تاعه فرضا central وعنده أزمة أو COPD تكون tracheobronchial تكون tracheal infection due to acute bronchitis فرضا ممكن يعمل لك central pain as well يكون هو acute as well radiation if it radiates to the left arm neck jaw this is cause of acute coronary more good radiation if it radiates for example to the scapula to the tip of the shoulder the back if the back is dissection between scapulas like if it radiates to the tip of the shoulder or radiates to the right upper abdomen quadrant pneumonia basal pneumonia right lower group pneumonias so this is important أحيانا يجوك pain here do you think that's an abdominal pain بس هو عنده كف when you examine him abdomen is free ما في عنده soft lax ما عنده nervy sign does not suggest a history إنه والله إنه gallbladder ولا acute cholecystitis do you decide when you examine him there's decreased air entry you did an x-ray you find the opacity there so this is right lower pneumonia so pneumonia the either from that give you hint might be give you radiate to the epigastric area ممكن تعطيك epigastric pain sometimes and sometimes might give you as well pain in the tip of the shoulder or the neck again ليش؟ لأن the lateral part of the diaphragm they are إيش؟ innervated by the phrenic as well symptom good associated symptoms حكينا fever night sweats fibers weight loss nausea vomiting بتهمنا كمان and sometimes gallbladder pain might be referred to the right lower as well تمام MI sometimes might be referred to the gastric area inferior MI especially in females ناس في بعض الناس ممكن يكونوا silent MIs old ages females all of these they might have silent MIs but females sometimes in inferior MI can be referred to the gastric patient comes to the ER complaining of the gastric pain he doesn't have يعني عنده nausea which is due to the autonomic stimulation due to the acute coronary syndrome nausea continuous here but sometimes you might not differentiate but you have to be meticulous in history which is which meaning يبلش في البداية and if there is any risk and always consider يعني whether young or old للأمانة which mean more you will be more يعني meticulous مع young ages than if you miss inferior MI often this يعني fatal in young ages الايجز الكبار ممكن يكون حظهم كويس يكون عندهم collateral vessels يعني تمشي امور تمام but you have to remember always sometimes especially if there is risk factors okay timing when it started when it comes, daytime, nighttime. The attacks, central attacks, wheezing, early morning associated with wheezing, comes in the early morning between 3 and 5. Mostly this is asthmatic attacks. Of chest pain comes while you are sitting, واحد قاعد معك كنت تحكي معه وصار عنده chest pain all of a sudden and he's young and he's medically free. This is panic attacks most of the time. Think about psychogenic causes. Good. Timing the pain after the morning. بعد المورنينج بلش يجي wheezes و chest tightness. COPD excellent. COPD أكثر. Young female معلمة تأخذ OCDs while she was يعني كانت تشرح في للطلاب في الكلاس and she did a PE. Okay, good. That's good. So timing is quite important. يعني timing, especially بالearly morning. هم جماعة الأزمة والMI والcoronary acute coronary syndrome. They often come in the early morning hours, بتشوفهم في الطوارئ بتكون now. So it's quite important. الA اللي حكينا عنها قبل تي عفوا aggravating factors. Radiation aggravating factors. So aggravating factors شو اللي بيزيدها؟ Cold air exertion. This is more of asthma. Exercise, post-exercise. What kind of pain and shortness of breath or tiredness that will improve or that will start? Yani during the exercise, asthma, shortness of breath, chest tightness. After the exercise, COPD. That's good. That's quite important to know. Yes. The asthma, sir, you're right. The asthma is after the exercise. During the exercise is COPD. Yes, that's true. So the asthma is after that, the airway hypersuppression after, subhanallah, wa bikun qdam shoghl. Okay, so the asthma is after exercise, and during the exercise is the COPD, the shortness of breath and the pain, the aggravation. Where perfumes, allergens, drugs, asthma, atypic, so كمان dusts, work, asbestos, work environment, fuel, occupational asthma. So those patients are often improve in the weekends and they have a long weekends as well. So all of these you have to keep in mind when you are taking the history of chest pain, because you don't know sometimes what's going on. You think that's serious, but while you are talking to the patient, you start to lift and lift and from a patient who is anxious comes to you, anxious to the emergency room, thinking he is infarcting to something simple while you are talking the history. So but you have to know what you are asking. So basically in medicine, if you didn't think about the differential diagnosis, you want to ask about it. So later on, inshallah, to school rotations, you will see when you start asking the patients, you will ask about what you are thinking, what's going on. But if you are thinking that patient might having a high or he's having asthma exacerbation, you will ask about the symptoms of both. But if you're not thinking about a VE, and you must ask about the specific questions of the VE, so we ask about what we think. I بعرف الميزان جدا. أنت بتسأل عن شيء في بالك، بس if you missed it معناته إذا ما سألت عنه غالبا أنت ما فكرت فيه. ما خطر في بالك. Good. So keep in mind all of these things. With time, inshallah, you will know that. T time حطينا الإيش exacerbating خلطنا الأمور associated الA exacerbating والS إيش severity. So الS severity how severe it is and how would you ask the patient يعني objectively to assess the severity. عندك ال 1 of 10 غير ال 1 of 10. لأن كمان لسه ال 1 of 10 is subjective للأمانة. ممكن you might be بس كمان again أنا عندي tolerate أنا بستحمل أنت ما بستحمل العكس صحيح أنا ما بستحمل هو بيستحمل تفضل. Good. So interface with daily life, this is most important severity, then severe enough. شو كمان? Excellent. So interference with daily life activities. Excellent. So awaken him severe enough to awaken from sleep. So I mentioned فإذا واحد صح عنه من النوم chest pain أو pain in general, this is severe enough to wake him sleep. We take it seriously. Okay, so we have a couple of questions that will make that will give you a clue how severe the pain it is. And still, بقول 1 to 10 still is more subjective. It depends. في ناس they tolerate يعني بتركب له كاثيتر وهو صاحي بدون اي اشكالات، مقابل واحد تحط له كانيولا بتصير شارجنج وهي الامور. So الامانه differs between people يعني you cannot rely on assessing pain. It helps. احيانا يستخدموا الجرافيكس الاوجه الايموجيز اللي بضحك العابس severe very severe هاي الامور. So it helps. There is different pain score assessment للامانه that depends on objective questions. في كثير pain score assessment scores. And that depends more on the objective assessment. So, site onset character radiation, associated symptoms, timing, exacerbating factors, and severity. This is the minimum that you need to remember about any pain, not just the chest pain. Any pain in general that can lead you للأمانة and map you while you are talking to the patient. Let's go to the slide next. Okay, now, weight loss, sleepiness, past medical and surgical. Past medical and surgical history these include respiratory disease that might occur, reoccur or cause them to. شو respiratory disease that you know that might reoccur؟ يعني infections in general يعني إذا في history of pneumonias it might be يعني why is that؟ إذا في history of شو كمان؟ TB might reoccur if he was treated. Yes, that's true. شو كمان؟ Connective tissue disease is the chronic disease, so it won't be يعني recur يعني we understand that he will be cured and be reinfected or reoccur. Vasculitis is connective tissue again, it's so chronic. So causes long-term symptoms or recur. You are right, both of you كلكم حكيت بس أنا كان بدي أمثلة على recur. Disease with other symptoms that might complicate or present with the respiratory symptoms like what? حكيتوا connective tissue, vasculitis. ها؟ Pneumoconiosis, شو هو pneumoconiosis? Occupational disease. Yes, that's true. Due to inorganic compounds. And pneumoconiosis is the big name. بندرج تحتيهم coal miner، بندرج تحتيهم شو كمان؟ البريليوسيس، بندرج تحتيهم ايش؟ بسمس. ها؟ Silicosis, excellent, you are right. بندرج تحتيهم. So it's the umbrella, the big name. بندرج تحتيهم ايش كمان؟ Connective tissue in general, vasculitis was also very nice. Thrombosis, you are right, this might reoccur. You mean thrombophilia? Thrombophilia, yes. Thrombophilia يعني إنه ممكن يصير عندهم BEs, recurrent BEs, they are liable to recurrent BEs. That is true. Huh? Hemophilia, hematologic disease, they present with symptoms of shortness of breath and chest pain. You are right.
Any abnormalities in GI?
Like? Yes, but cannot be GI more specific thing. GERD, Cystic fibrosis, excellent. Bronchiectasis, CF and non-CF, that's true. Yes, anemia, hematological زي ما حكى زميلك بكل الأمراض بكل الثلاسيميز السيكل سيل anemia will be reflected and give you. The gastric hernia, often these type of hernias, they are a resultant of chronic respiratory illnesses, especially chronic cough, those who have chronic cough. Nas and chronic cough, they have increased intra-abdominal pressure always. So, and at a given time, there will be weakness and they will develop epigastric, umbilical, parambilical, and even violent hernias. So all this relates to the chronic increase of intra-abdominal pain or pressure, intra-abdominal pressure related to the chronic cough. Regarding the GI, حكيتوا GERD, حكيتوا شغلات كويسة. IBD. Yes. Inflammatory bowel disease have as well extra-intestinal manifestation. Celiac have extra-intestinal manifestation. Okay, sarcoidosis as well. So interstitial lung disease. So there is other symptoms, other systems, not just the respiratory that can affect the respiratory. And from these diseases that are not non-respiratory diseases, the medication that are given to those patients or those diseases might affect the respiratory system as well. Like what? Methotrexate. It's a general is used in rheumatological disorder, antifolate, medication, immunosuppressant, that can cause what? Affect, how it would affect this person? Fibrosis, number one. Okay, good. Bleomycin, excellent. Causes bleomycin toxicity. Where it happens mainly, when it happens, and what will increase the bleomycin toxicity? Sorry, let me rephrase it. What increases bleomycin toxicity? All right, bleomycin is toxic to the lung, causes lung injury and eventually fibrosis. But how? What does increase the risk of bleomycin? Here, this is advanced, but it's good to know about it. Alpha-1 antitrypsin is a disorder that rare disorders like the cystic fibrosis and this stuff that affect. We'll talk about in the family history, but when I'm talking about past medical, you're right. Like that doesn't mean. Bleomycin oxygen. For any patient, you have to be careful. في الناس اللي بياخذوا الجيتر إن شاء الله استخلصوا بياخذوا chemotherapy. And one of the regimens of the chemotherapy is bleomycin. High concentration of oxygen will increase the toxicity of bleomycin. So just to keep it in mind. This is a piece of information مش ضروري يعني ما لها علاقة بالامتحان, just good to know. Good. Other than methotrexate bleomycin, aspirin, how would it cause? How would it cause? Aspirin toxicity says toxicity causes biodigestion. Good. Busulfan. So you can name it. So there is a lot of drugs. يعني mainly immunosuppressant drugs. Sulfasalazines. هذول اللي we use from the IBD product. ACE would cause what? Cough. By the way, good. Dry cough. Good. Good to mention that. Thank you for raising this point. So, what will you advise the patient? First, all of them they will do good cough. Right. How many? Any ideas? Any answers? How often or how common the dry cough induced ACE by any ACE inhibitor will happen? Or what's the percentage of the people that might be affected? 80 to 90. 80, that's too much. That's too much. Up to 15%, أنا بحكي. As far as I'm concerned, as up to 15%. Sure. بعدنا بالايس بس شوي خلينا في نقطة بدي تعرفون ليش. So up to 15%. And it often occurs in the first 3 months. But if it happens, حكيته, you ask him to switch لإيش؟ للأربس. طيب إذا ظلت, what you should talk to your patient. Your patient comes to you again, دكتور غيرنا صار لنا أسبوعين 3 4, still I'm coughing. Good thought. You should rule out another cause. طب إذا ما في شيء, تفضل دكتور. It will cause angioedema, مش كف. ما احنا وقفناه، هو الأربس وانت الإيس وقفتيه، الأربس بيشتغل على ريسبتور. فيو ار رولينج يعني getting from bradykinin المشكلة. طب هو الأربس بيشتغل وين؟ على ريسبتور. فاذا براديكاينين هو مشكلتنا كان في الايس الانزيم نفسه. هو الانزيم بيعمل انهبيشن بيزيد الايش؟ الباي برودكتس اللي قبليه، الستيب اللي قبليه. طب هسه مش مشكله شو راح تعطيه، بس يعني what you talk to what you tell your patient. براديكاينين ما بنعملهاش. بس انتوا قريبين. بس يعني you need to know that the cough from ACE inhibitor might last up to 12 months. Good? تمام. Next يا صديقي. لا في سلايد قبلها. Good. في الباست ميديكال هيستوري كمان شو كمان بهمنا؟ هي فيفر، allergic rhinitis، اكزيما هو صغير، visits ER visits for nebulizers that give you إنه كان عنده childhood asthma. Some of them they continue this asthma with them and they take it to the adulthood and it will be chronic and he will be asthmatic. The other, so it's third, rule of 3. 1/3 they remit, 1/3 they continue. Good. and 1/3 they remit and they develop later in life. So we diagnose asthma at 60s and 70s, عادي. And we diagnose it at earlier ages. Measles, whooping cough, inhaled foreign body, recurrent pneumonias, bronchiectasis, patients اللي عندهم recurrent chest infections وهم صغار ضلوا بعدين they are daily phlegm producers بحكي لك. Always you start thinking, and there was a crackles on the exam, inshallah we're going to talk to you about the physical exam today and tomorrow and the day after tomorrow as well. So you think about bronchiectasis, daily phlegm production at early ages due to recurrent chest infections as well. TB, history of TB, either reactivation, reinfection risk is low, especially if you were living in low incidence TB countries. يعني لما تروح على الغرب او هاي الامور unlikely لما تكون انت في جنوب شرق اسيا او في افريقيا. اوكي. Pneumocystis, connective tissue diseases زي ما حكيتوا like fibrosis, pleural effusion, bronchiectasis, rheumatoid arthritis per se can cause all of these. Can cause bronchiectasis, lung effusion, bronchiectasis, and fibrosis and rheumatoid nodules as well. Previous malignancies, recurrence, treatment, late complications, either ناس في عندهم those who get lung cancers or lymphomas. Lymphomas can invade as well, can happen in the can occur in the lungs. ممكن recurrence of the primary cancer صار عندهم. تمام. ممكن during the treatment another primary because the chemotherapy and the radiotherapy as well they might induce another primary or complication, late complication, radiotherapy induced pneumonitis and like fibrosis, and this happens. Often it needs around, and it develops after 6 months. And it started slowly, gradually, insidiously, but after 6 months you will see the effects of the radiotherapy sometimes. For example, one of these. We have immunotherapies, you know, oncology medicine is evolving rapidly like a jet, سرعة الصاروخ للأمانة, which is fantastic. Nowadays we have immunotherapies, we have biological therapies, but a good number of them we have side effect of the lung causing pneumonitis as well. So you have to bear in mind that. Good. Next. Current malignancies, زي ما حكينا كمان زي ما حكيتوا, lung travel, mobility, all the risk factors. So while you are taking the history, you have to think about the risk factors of what's going on. Now, so what do you think of your differential diagnosis? So the questions come from what you think. So if you think about venous thromboembolism, you should ask about any risk factor. If you think about connective tissue disease, you should ask about different symptoms of connective tissue disease, skin rashes, joint involvement, all these stuff you should ask. Okay? So questions come from what you think, from these factors. Recent surgery, loss of consciousness, aspiration. You think about aspiration. Your colleague mentioned there is aspiration. So alcoholic, alcoholic, like unconscious sometimes to go back, although they are more liable to aspirate. There are foreign bodies, teeth, sometimes broken teeth, foreign bodies. Okay? Neuromuscular disorders as well, like myasthenia or ALS, amyotrophic lateral sclerosis, progressive neuromuscular diseases will cause, often sometimes causes aspiration and respiratory failure. Good. Next. Drugs and allergy history, bronchoconstrictions. ففي الدرug زي ما حكينا, drugs that might affect the lung and drugs might affect the airways, like beta blocker, NSAIDs. NSAIDs شو حكيت انت الاسبرين, you're right. اسبرين بس low dose و high dose بفرق معك. That ibuprofen, هاي الامور the causes they should be ideally they should be avoided in asthma. تمام? Especially in those aspirin, especially on those they have Ramstein triad. Do you know, anyone knows what's Ramstein triad? Asthma, atopic asthma, nasal polyps, aspirin allergy. Okay? Aspirin allergy, atopic asthma, nasal polyposis. And this triad, whenever you see this triad, you go to one patient in my home. The best treatment for them is just not the inhalers, to be honest. Montelukast, leukotriene inhibitors. Good. Cough, زي ما حكيت, is inhibitor, antecessor, cytotoxic agent, anti-inflammatory. Amiodarone and nitrofurantoin is they were used quite often in the past. لأن for arrhythmias in general, but Nowadays we don't like to use them. الكارديولوجي غير شوي لأنه there is good new drugs. Still there is some يعني you need amiodarone يعني في بعض الحالات ما في شيء بغني عنه. لكن still we try to avoid it as much as we can. Nitrofenitone is an antibiotic used previously for UTI infections and prophylaxis for those who have structural or vesical reflex, especially in females. Venous thromboembolism زي ما حكينا الOCVs الاستروجين. By the way, which is which? عندك الOCV وعندك الميني بيل. Who does increase the risk more? الميني بيل اللي هم البروجستيرون containing only pills. الOCVs اللي هم combined ولا لا؟ مين اللي بيزيد؟ عندك الOCVs بيزيد أكثر مضبوط. البروجستيرون أقل. طيب الOCVs in all generations, the first, second generation, they have higher risk. Second generation أخف. But nowadays they have the fourth and the fifth generations. اللي هو للأمانة they carry less risk زي levonestrogen or they carry less risk for regarding thromboembolism. Next. Pulmonary hypertension, estrogen and fluoramine. Just to know about fluoramine is a serotonergic anti-epileptic. Was used to special type gestational seizures syndrome for special type of seizures caused by this syndrome, serotonergic. And also was used primarily, it's now withdrawn from the market, primarily for appetite suppressant for those who want to lose weight. But they found that it causes pulmonary hypertension. Pleural effusion, زي ما حكينا, amiodarone, nitrofenitone, phenytoin, methotrexate, variglide. Variglide is the antidiabetic which is withdrawn from the market as well. Respiratory depression, benzodiazepine, and opiates, or salicylate, as well as respiratory depression. Next. Family history, اللي حكينا, اللي some of your colleagues mentioned about the cystic fibrosis. It's a rare disease affecting the Caucasians mainly, Caucasian Afro. The incidence, يعني it's believed that 1 out of 20, they carry the mutation of the CFG. Okay, and the incidence is around 1 to 2,000 per 1 birth per 2,500 births. The incidence of cystic fibrosis in the Caucasians, especially in UK and the surrounding areas. Okay. Alpha antitrypsin حكيت عنه يعني very rare but it happens, it occurs, and we have heterozygous homozygous. لما يكون heterozygous الجماعة they present like homozygous, they present earlier and not just with the lung diseases with the liver as well. Siblings, family history of asthma or atopy. Atopy it's something runs in the families sometimes. And IgE should be elevated in addition to asthma plus dermatitis, atopic dermatitis, also for eczema. Good. Sibling with cystic fibrosis, this increases the risk. They carry the mutation of the CF gene, CFTR gene. It's an autosomal recessive. Again, alpha-1 antitrypsin is an autosomal recessive disorder as well. Next, please. Social history, level of daily activities that give you a clue about how the disease is affecting the patient. زي ما حكينا objectively. Home circumstances, why is that important? ليش مهم home circumstances? Socio-economic مهم ترى لأن في specific diseases or disorders that come يعني you see it more often in those socio-economic areas. هاي الهوم الاوكيوبيشن بعدنا ما حكيناش عن الاوكيوبيشن. Talking about the home and the occupation. Your point in the occupation. That's good. The home.
اطلع شوي.
ده دكتور. Ventilation. ايش ventilation؟ دكتور؟ ايش؟ رفعت ايدك. Ventilation. Why ventilation is important? That's good. الهيوميديتي زي ما حكى زميلك شو دكتور؟ mold or dampness, that's true. لما تحكي لهم في عندكم رطوبة وعفن في البيت, that's quite important. Any asthmatic patient, you should check, it comes to you, you should check that, you should ask for that. For those who have more than dampness في بعض البيوت بيكون عندها أسود هذول whatever you treat بيكون أمراض they are more risk of developing something called ABPA شو allergic bronchopulmonary aspergillosis لأن هي عبارة عن fungi هذا هو عبارة عن aspergillus عن fungi so one of these modes تهوية ventilation those socio-economic اللي بيعيشوا في مناطق مكتظة they're more liable of getting TBs like الجماعة اللي في يعني India وهاي الأمور. Why is that? Because of that. لما يكون البيشنت عايش عندهم في الغرفة 4-5 and they have close contact and he's coughing for at least يعني 2 to 3 weeks and they catch the TB as well. So all these socio-economic social home circumstances they are quite important. That's true, yes. There is studies about that, am I right? Which is which? Meaning more at risk or less at risk? Because they see the sun more. السن غالبا اللي أكثر تشرق عليهم أكثر على عكس اللي يكونوا في الطوابق الأرضية في التسوية. That's true. You're right. That's true. Maybe as well. So there is a lot of things. You're right. There is a lot of things. Radiance, a lot of things. Smoking, عندنا الباسيف وعندنا الباسيف سموكينج وعندنا الاكتيف سموكينج. سموكينج بارير اهم شيء تحسبونه السموكينج بارير اللي هو how many cigarettes يعني I was asking cigarettes in average how many cigarettes per day multiply or how many يعني smoking years multiplied by daily packets that barrier. بمعنى آخر هو دخن for example 20 سنة and هو كان يدخن كل يوم تقريبا باكيت. الباكيت في تقريبا 20 سيجارة تقسيم 20 تمام تقسيم 20 فبيطلع عندك 20 باك بير يير. For those يعني COPDers often comes after يعني unless they have a predisposition genetic predisposition اللي هو الألفا 1 تريبسين ما عدا ذلك a part of that they usually ideally they develop if they were to develop COPD after age of 45 with a history of 20 back per year. Okay, so it's important, quite important. You have to memorize that. Alcohol drinking, aspiration pneumonia زي ما حكينا because there is subconsciousness on the list. Occupation history اللي حكيت عنها asbestos شو كمان؟ asbestos which occupation؟ وين رايحة صديقي؟ ها؟ والله خلصت؟
أنا 5 دقائق.
والله ما شاء الله عليك، الله يسر امورك. شو اسمك بس انت؟
احمد بن اسماعيل.
ممتاز، الله يقويك. الله يقويك. لا ما شاء الله ميتيكولس دقيق جدا. بنشوفكم. Okay, next. So this slide contains about what's going on in Jama'ah and how things will occur. Farm, heavy industry, factory and farm, and lumber shipbuildings, this are the occupations that result in different respiratory disorders as well. Next. Systemic inquiry, always review the other systems about زي ما حكينا other diseases will affect the respiratory symptoms, the respiratory systems, زي IBD وهاي الأمور. Remaining history often reveals unsuspected pathologies presenting with respiratory symptoms or indicating respiratory illnesses. Next. These are the parts of the history taking we were talking about. Any questions so far, Jama'ah? Any questions about any parts? So المفروض انتم باي ناو اخذتوا الهيستوري بارت كامل فالان اليوم عندكم كيس ان شاء الله يعني تشوفوا different to the other cases that يلا بالتوفيق.